So in 3 weeks, I will go to Murcia, Spain, at the Spanish Orthopedic Society, and there I have workshops
Doctor, ya
and
estamos en vivo.
presentations.
Excuse me, Dr. Longo. Let me introduce you first.
Okay.
Buenos días para todos. Muchas gracias por estar presente en esta transmisión en vivo. Tenemos en este Ateneo, en la oportunidad de hoy, tenemos unos grandes invitados para tener una discusión en las siguientes 2 horas muy interesante acerca de artroplastias de tipo colona y artroplastias de reducción, cirugías muy especializadas en ortopedia infantil. Voy a compartir un segundo mi pantalla para introducirles a ustedes a nuestros invitados de hoy. En esta oportunidad tenemos invitados muy especiales. Desde Suiza tenemos al doctor Tedis Longo, una persona que lleva muchos años de experiencia en el área de ortopedia infantil y trauma pediátrico. Como ustedes ven, 48 años de experiencia en este campo. Es una persona que se ha especializado en la cirugía de la cadera pediátrica, hace reconstrucciones muy especiales como esta que vamos a tratar el día de hoy, que son técnicas especializadas en cadera infantil y del adolescente, que son cirugías que requieren una amplia experiencia para realizarse. El doctor Longo tiene una experiencia de más de 140 cursos en ortopedia pediátrica, ha hecho workshops alrededor del mundo, en modelos óseos, en pacientes, opera en diferentes lugares del mundo. Es miembro de la Pediatric Education Task Force de la O. Es coautor del nuevo currículo para educación en ortopedia pediátrica. Ha hecho producción, es una persona muy vinculada a la docencia. Afortunadamente para nosotros en la universidad, ustedes entienden que es muy importante este enfoque hacia la educación. El doctor Longo tiene amplia experiencia en esto también. Es profesor de múltiples estudiantes y fellows en el hospital universitario, en el Instituto en Berna, que saben ustedes que es uno de los principales o el principal hospital de ortopedia en Suiza. Es el director del Max Frame Task Force de la O y miembro del grupo de expertos en pediatría, en ortopedia pediátrica, miembro del Joint Preservation Global Expert Committee y miembro de la OTA, de la Orthopedic Trauma Association. Entonces, como ustedes ven, una persona con amplísima experiencia. Vamos a tratar de tener el jugo, exprimir todo el jugo a sus conocimientos. El doctor Sergio Noza, una persona de la casa, es ortopedista y traumatólogo de la Javeriana, realizó su especialización en ortopedia infantil también en la Javeriana y posteriormente ha hecho múltiples profundizaciones en este tema. Una persona con amplísima experiencia también en el tema, hizo un observership en el Pediatric Orthopedics en Escoliosis en Texas, en el Scottish Rite. Asimismo hizo un Clinical Unit Research Fellow en el Paley Advanced Limb Lengthening Institute en Florida. Y hizo un fellow de trauma con la O en el Children's Hospital en Infantil, donde conoció al doctor Longo, y el doctor nos ha sido nuestro puente con el doctor Longo. Trabaja hoy en una de nuestras instituciones hermanas más importantes y con mayor relevancia en este tema de ortopedia infantil, que es el Instituto Roosevelt. Entonces, pues es un placer contar con la presencia del doctor Noza para que también lo vamos a exprimir en todos sus conocimientos y en toda su experiencia en este tema. Mi presentación personal para los que no me conocen: mi nombre es Luis Fernando Useche, yo soy el director del Departamento de Ortopedia de la Universidad Javeriana en este momento. Tengo una gran cercanía con el instituto, trabajo en el Instituto Roosevelt, tuve la oportunidad de vivir en Suiza en el año 2007 y también participar en el entrenamiento de estas cirugías de cirugía de preservación en luxación controlada. y trabajo pues con grandes especialistas en el Instituto Roosevelt, entonces tengo un interés particular en este tema, por esto estoy de moderador y agradezco muchísimo la invitación al Instituto Roosevelt por pues permitirme moderar esta sesión. El cronograma que tenemos, el programa que tenemos para esta mañana, para estas 2 horas, es un cronograma bastante cerrado y concreto. Tenemos una presentación primero del doctor Slongo en artroplastia de colona y reducción de la cabeza femoral. Tenemos a las 7, a las 8, alrededor de las 8, una sesión de preguntas para el doctor Slongo. Tenemos a las 8:15 la presentación del doctor Nosa, de la experiencia que hemos tenido en el Instituto Roosevelt con estas artroplastias y con las artroplastias reductoras y una discusión final. Estamos muy atentos a todas sus preguntas, por favor no dejen de escribirlas en el canal de YouTube, en los chats que se han compartido con todos ustedes. Entonces, pues sin más, le doy nuevamente la bienvenida a nuestros 2 expositores. Dr. Slongo, welcome. Thank you again for your time, for joining us in this special event for us in the Pontificia Universidad Javeriana with Instituto Roosevelt. For us, it's a pleasure and also an honor to have you here and to learn from you and from your vast experience in this field. Doctor Nosa, muchísimas gracias por estar acá con nosotros, por compartir con nosotros su experiencia, por su tiempo, para llenarnos de conocimiento en este nuevo Ateneo de la Universidad Javeriana. Muchísimas gracias y empecemos entonces. You can go ahead, Dr. Sloan.
Okay. So first of all, thank you very much to invite me for this really good webinar here online at this day, so early in the morning for you. For me, it's after lunch, but it's much more comfortable for me. And again, it's really a honor to be with you, good friends from South America, because over the last 2 years, I missing so strongly not to travel to South America. Normally, I come for 2-3 times to South America, and this is my best place. So this is my second home, I will say, and especially also for Colombia. The last time I was more in Medellin than in Bogota, but I like also to be in Bogota as well. So there again, believe me, this is really a great honor, and I hope I can come back soon to your country and to South America. Really, it's my second home. Now, today we will start, and now I will share my screen. I hope everything will work. Just a moment. It's always okay. I hope you can see the full screen. It's okay?
Yeah, it's okay. It's perfect, Dr.
Good. Okay. So Sergio asked me to speak about our experience in the colonoplastic, or we can say also to how to manage long-term neglected hips. And I know, as I mentioned before, I'm many times in South America, especially my big experience in surgery is from La Paz in Bolivia, because I was there 3 times for a long time, and I have seen how many neglected hips you have in your continent and especially also in your countries. So this is a big problem for you, and I guess today we have a quite good solution even to treat neglected hip. But I will speak during my presentation about this. We must be careful, and it needs a lot of experience, because this two types of surgery I will present today is the high-end surgery in hip ever you can do. This is the top level of of hip surgery, and this is really, not an operation for starters. So what is the main problem? Maybe we go shortly to this problem. These are the undetected hip dislocations. then we have to ask why we see this. Of course, I know the problem is not hip screening available or used as we have it in Switzerland, and NOSA and all knows it. They were in Switzerland. We have another approach to the hip than in your country, but this is not your fault because the population is in countryside. They have no access to doctors and so on, and this is really a big problem. But for me, there are other problems. Wrong assessment of the investigation. Sometimes I get a X-ray sent it to me. I see X-rays, but the colleague outside did not recognize the problem, and this is really a teaching purpose. So. And the other problem, as I mentioned, the doctor did not see the baby because it never had access to a doctor. Or again, it's the doctor problem, the ignorance of the problem. Wrong initial treatment is also a problem for me. Perhaps the conservative treatment with public harness for a high dislocation. Tell me how a high dislocation can be treated by public harness. But we have also high dislocated hip, but young patients, babies, 2, 3 months, and we can treat it in a conservative way, but with the correct equipment. And then I see a lot of cases, neglect cases, they underwent an operation, but I see this was the wrong approach, too violent, and especially the wrong technique. And what we see also, even in our country today, sometimes parents refuse the treatment. So when we see such hips, of course, this is a problem. So the incidence of neglect hips, of course, is in our country very, very low. I would say 98% in the meantime of all babies get the sonography after birth, and that means in the first months of life. But we know bilateral clinical signs are difficult to see because of the symmetry. I see sometimes even also here in Europe a bilateral dislocation not detected. But the monolateral dislocation is more frequent. And I don't know what is the incidence in your country and as we see here in Switzerland, of course. Sorry, I have to change a little bit my headset. It's not in a good way. Sorry. Okay. So the question is now, when we see such pictures, this is a case from Bolivia I mentioned before. It was sometimes sent to me sometimes ago. So the question was, Dr. Slongo, can we do something in a child of 7 years old? And this is a big question. And in a lot of cases in the past you have seen end up in a disaster. So sometimes it's better nothing to do. And even in our hands, 20 years ago, we said bilateral high dislocation, don't touch it because later on it's worse than before. But nowadays, we can offer this patient a good solution, and you will see how to do this. So what to do in such a situation? You see here, what I like to see is also an abduction view, and even in the abduction view, we have no reduction. So what are the considerations? What we can do or we are able to do. You see, these are two different things, what we can do or what we are able to do. And then the next question is make it sense. You have to think always about the sense. Not everything operation we can do makes sense for the patient. Be careful. So a careful reflection, I would suggest to discuss before you treat such a case, discuss this with some colleagues because it's never urgent surgery. And you have to think about what will be the future of this hip when you do nothing or you do something. And what will be the profit for the patient when you make an operation? Because at this moment, he's walking, no pain. But if you make a wrong operation, he will have a stiff hip and pain. So the result is bad. And you have to discuss the complications. So what we have to consider is, especially the age. Then we have to analyze the situation of the acetabulum, situation of the femoral head, additional disease, a CP, and had the patient previous operations. Of course, all these 5 factors are important to consider, to analyze. Very often we see an X-ray and directly we ask what to do. No, that's the wrong question. First, we have to make the analysis of all these points. So what to do then when we have such a case depends on the experience skills of the surgeon. And as I mentioned before, and we will discuss this during these 2 hours, the skill of the surgeon is important. So again, it's not the beginner's operation in this age. Depends on the technical possibilities you have. I was in China. I have refused operation because they had no equipment. It needs also a good team, good optimal operation technique and equipment and instruments. A traumatic approach, you have to learn how to go to the hip because the approach to the hip is not the main operation, it's only the approach. And you should not have complication only by the approach. And you should avoid AVN by sufficient treatment. As you can see here on the right side, you know, this is important. I guess you see my laser point. You see, this is not the result we like to see. Okay, now what to do if initial treatment was not adequate? You see here some examples. You see here a typical dislocated hip, conservative treatment end up in this disaster, So in our hand, I would never see again such a case. And a lot of you will say, oh, we know this happens, but no, this has not to happen if you make the correct treatment. Or look here, this hip was treated in an open reduction and then in a kind of Salter osteotomy. And here we have an AVN after treatment. And then, even this is the same case, because of the insufficient treatment, the hip went out and we had a necrosis of the femoral neck and everything. And we end up after a new operation in this situation. Or have a look at this, the wrong technique. In this case, it was operated by open surgery and Salter osteotomy, and this was the result. The hip is not in, still out. So you agree with me, that's much better to wait and see. And nowadays, if a child is 2 or 3 years old, I say wait until the child is 7 that we can go for a colonna. And you see, this is a disaster. And once you made such an operation, a colonnoplastic is not longer possible because you have scar. What you will see, the colonnoplastic needs a healthy hip, a healthy or untreated hip. Okay, so the question is, what is too late to reuse a hip, a dislocated hip, and how to prevent complications? Or there is no time age limit. Yes, today in our hand, there is no more time limit, but you have to wait until the child is older. That means for me, if you see a neglect hip between age of 2, 3 up to 7, don't touch it. It's better to wait because the child has no disadvantage and then you go for a correct operation. So in my hand, I manage this in 3 groups. That means the first group is up to 3 years. The second group is 3 to 10, and then over 10 years, as you can see here. So, but what you have to learn also is to analyze the different problems. First of all, in a dislocated hip, this is the hip exists from 2 parts, the acetabulum and the femur. And a dislocated hip is not the problem of the femur. This is wrong. Therefore, it's not necessary to manage the femur. No, it's a problem of the acetabulum. Okay, so we have to look at the acetabulum. Is it spherical or aspherical? And how looks the cartilage? So this is the point we have to look, the acetabulum. Of course, the femoral head we have also look. The femoral head existing or not existing. So the second point is that we look then at the femoral head as well. But we have to analyze both and then the relation of both. Okay. So the next point is when we see such a hip, I know today you go very quickly to a CT scan or MRI. In my hand, this is waste money Because if you learn to read an X-ray, you can manage this without MRI or CT scan. So what we can see and what not. What we can see here, this is the femoral head. Of course, it must be here, and this is the missing part because of the pressure to the dislocated to the pelvis. This is important. So then, up to 3 years, the group 1, 10 to 40 needs skin overhead traction and relax the muscles. Gentle open reduction by Smith-Peters approach. In our hand, a femur osteotomy, shortening the articulation is really not required. I never did this over the last 40 years, and I did many of these cases also in South America, and they were all astonished not to make a femur osteotomy. I learned this from Professor Gans. It's not necessary, you will see. Then I have the second group, 3 years up to 10. Then we can go for gentle open reduction if you do this. In our hand, a femur osteotomy shortening is not required even in such a high dislocated hip, as you will see. But then you go for triple osteotomy, or you can go for colonoplastic up to a third year. And then the last group is the group 3, children older 10 years, and then for us, we go direct to colonoplastic. So the next question is in our eyes, it's not only faithful that we have such situation as you can see here. There are high risk factors. And in my eyes, the main risk factor of such a neglect hip is the surgeon and not the case and not the patient. In the second step, it's again the surgeon and then the approach by the surgeon and then at the end the situation. But the surgeon is this. So, solution today for patient older than 5-7 years. The colonna arthroplasty for dislocated hip of adolescents and young adults or safe over a safe surgical hip dislocation. And this is now the key. When colonna or high growth started with this surgery, they had 50% of this failures because they were not able to make a safe surgical hip dislocation. And the introduction of the surgical hip dislocation by Professor Gans here in Bern and in our clinic, this offers a new option also treat this. So short history, Sergio will show this again. They published in 1932 drawings of the procedure for reduction of high dislocated hips, illustrated with 3 cases only. But this information is a part of the quality report and the result of different options later on. So, okay. So these are the original drawings. You will see it again. But he did it by the traditional approach from lateral, from anterior or posterior, but in a dangerous way. And therefore, very often he fails. So Colonna worked at this time at the hospital for the reputed and crippled in New York City, today known as the Hospital of Special Surgery. The technique he did was performed in 2 stages, first traction and then the surgery. Over the years, Colonna published it in several journals and articles and in 2 textbooks. But then later on, everybody forgot this operation because of the high number of complications. A few cases needed the rotation femoral shortening. Of course, this will be different here, you will see. And then you see other people started then also to do this, and we know this from the literature. I will not go in this. And these are some publication. You can see this later on, and you will hear this from Sergio again. Coming back to these original drawings for Colonna, you see, of course, he made a shortening, and we do a shortening as well. But I will explain why we have to do a shortening. We'll see in the operative technique. So, another point of the history, Professor Gans himself had his first confrontation with the colonna arthroplasty dates back in the late 70s, when he had the chance to assist this and his and later also my mentor, Professor Müller. Muller did some colonna, but with very bad results as well. And then again, Professor Ganz did not again such operation. My first contact then in the modern kind of colonna arthroplasty dates back to 1995. That means really 27 years ago, when Professor Ganz and I did the first case by a new and safe surgical hip dislocation. So the key to the modern type of colonoplasty was the ability to make the hip dislocation. So this, you see, is one of Professor Ganz' cases at beginning, colonna with 25 years. It looks quite good. It was a male, 31-year-old. On the other side, he performed a PIO. But then in the age of 48, that means 23 years after colonna, he had to convert to a total hip. But this is quite a good result. Then the patient is nearly 50 and is a good age also for a total hip. And you see on the other side the colonna. So what was the key for the better approach and outcome of the colonna arthroplasty? Of course, this was the surgical hip dislocation and the blood supply. So this is the key, of course. So here, our first new case, 13-year-old boy, a girl, operated in 1995 with this typical situation. Dislocation with neoarthros. Abduction view, no reduction, you see here. Then we performed surgical hip dislocation, reaming of the acetabulum. In this situation, I will show you why you need augmentation, because otherwise it's too short. And even you have the capsule inside, this creates fibrous cartilage and not hyaline cartilage. And you see how nice the situation is in this case. So here you see the case then and the shortening 1 month after operation. What you need is a acetabulum reamer like you have it for the total hip. And the augmentation is mandatory as you see it here. And here you see now 6 years post-op looks nearly as an absolute normal. 10 years post-op, nearly normal hip, similar lengths. And this young lady makes every day 2-hour sports. This is now 17 years post-op, and we have controlled the lady now after 22 years. Still the same. You see, a good acetabulum, good cartilage, but it's not hyaline cartilage. It's still, and here you see in the axial view as well, 94 and 17 years later. I says this is really a fantastic result. And here you see this young lady. Again, remember what I said. She makes every day 2 hours sport. Therefore, she has a good condition, as you can see. She is running and everything. And you see no Trendelenburg sign. Absolutely symmetrical situation on this side as well, a little bit. And you will see the range of motion is even also normal. You see here on the right side, this is a normal for her and absolutely the same flexion in this way. And then again, also again, a deflection and extension. And here abduction is nearly symmetrical, you see, and internal external rotation is not absolutely symmetrical. As you can see here, this is a little bit limited on this side. So the surgical step again for this operation is first surgical hip dislocation. And the surgical hip dislocation starts with the correct positioning. This is one of the key. We have a tunnel or the block. Then the typical approach, you can read this in our publications, trochanter flip, osteotomies, as you can see here. I will not go in detail on the surgical hip dislocation, only as a memory. In younger patients, we do not trochanter flip, as you will see. We go by a transgluteal approach in this way, as you can see here on this new picture on the left. You remember, for the surgical hip dislocation, we open the capsule in a Z shape. But for this surgery, because we have to disattach the capsule from the whole acetabulum, we need this kind of cut. But again, this is the cut, never along the neck, then you will destroy the vessels, of course. So here again, this case, Here in animation in yellow, as you can see, this is the capsule. Then again, so one cut of the capsule starts lateral, goes over this along the anterior aspect of the acetabulum, around the acetabulum, and the next cut is then around the acetabulum on the back side. So this is the cut. We open the capsule and disattach the capsule. And again, if you have an open reduction before, you cannot do this operation anymore because the capsule is scarred and too small. Here, this is from our publication from Professor Ganz and myself, how we open the capsule and disattach it from the acetabulum. So in the next step, then you need the reamer, and you have to ream, and you must be careful in a correct way, the acetabulum, as you can see here. So then you have a good acetabulum. In the next step, you have to close the capsule over around the head in this way, first backwards up to the top, then in front in a Y shape, as you can see in the drawing, and this is the closure of the capsule. And now I explain you why we make shortening. You know, we have shortened muscles, and it is absolutely difficult to bring now this hip into the acetabulum because we have to reduce the proximal femur in an absolutely tension-free position. Otherwise, you will disturb or open your suture again. So therefore, we have to shorten 1.5 or 2 centimeters. But the shortening is subtrochanteric. So this is the shortening. And then we take this part and bring it back. This is the key. Otherwise, you have to manage the reduction in a difficult way. So what we do then, first, before we make the cut, we attached a 6-hole plate on the front of the femur with 2 screws. So I do this before I make the cut, as you see here. Then I remove the plate again, or I cut here my block away, and now I reduce this to the hip, and then I bring the distal part to the proximal part and make the fixation. This is the key. The plate is my handle to reduce the head in a tension-free position. Sorry, here now you see, sorry, it's not very well reduced, but you see now when you do low shortening, the reduction is very difficult. Okay, what we are doing with the resected bone, we create a bone block, and then, sorry, I go shortly out. By the presentation, it shows not correctly the situation. Sorry, I will go shortly back to here. Okay, so you see here in principle, we have the bone, and I will bring it back to here. Okay, sorry. So now it's correct. Now we have the reduction, and you will understand now why we have to do the shortening. And in the next step, we make the block, and this block goes then for augmentation, and also this is not in the correct position. Sorry, this has to come to here, the block to here, and the screw to here. Sorry, again, before it was correct, but sometimes this is the effect. So here, this is then the augmentation, and you see now, this is the result. Now here, other case. In this situation, Professor Gant did also a splitting of the head. That means in my second presentation, I show how to do this. Okay, so here you see the result, before and after in a small situation, and the good result after 12 years. Now, a very interesting case, a bilateral situation. You know, I did this in South America, in Chile, in Valdivia. You know, this is bilateral. They made a CT scan. For me, it looks nice for the parents, but it doesn't help to me. So I would never make a CT scan. For what? I see the problem, I know the problem. This is, but if you have too much money in the clinic, then you can do this. So here, I started on the right side first, as you can see here, the augmentation, very nice. Here the augmentation, good centered hip, you see, shortening, and now the good function. And then you see this was in 2019, 50-year-old girl. Then I did the other side half a year later. You see the left side looks similar, augmentation, everything. And here is the girl. And I guess you can understand she is speaking to me, and perhaps you can understand she's walking and she's very happy. Okay, okay, let me see. Yeah, she was very happy. Okay, so this is now the situation in 21. See, looks very good. And now she has still some waddling gait, but this is the missing of the training, and you can make this with physiotherapy. But function again is very well, you see here and here. So my message, the Codwilla Haygrafts colonial capsule arthroplasty remains a useful operation for a high subluxated dislocated hip in young individuals when accessible reorientation is not indicated. The femoral head must have the reasonable cartilage quality. AVN can be avoided and results can be improved with additional techniques as a surgical dislocation, relative neck lengthening, and femoral head reduction osteotomy. Good results up to 25 years when unilateral and operated before 20 years of age. Thank you very much. Muchas gracias por tu atención. Thank you.
Thank you very much, Dr. Longo, for your first presentation. Dr. Sechi is already here.
Okay.
Dr. Usechi, you're in mute. Está muteado, Dr. Usechi.
Thank you, Dr. Longo, for this wonderful presentation. Sergio, tenemos preguntas en el canal.
Sí, tenemos dos preguntas. Dr. Longo, did you want to go for your second presentation, or did you want the questions that we have for your first presentation?
I guess it makes more sense when we answer the question right now, because otherwise then it's a little bit confusing.
Perfect. We have two questions for
first,
you.
From my side, again, I hope I tried. Yeah, okay. What is the first?
The first question is in patients that you treat in between 3 and 10 years, you said that for those patients you usually do just triple osteotomies, correct?
Yeah.
The question is if you sometimes go for acetabuloplasty like San Diego, Dega, Pemberton.
When you understand, I have to explain this. When you understand the biomechanics of a hip and what happens inside, then you understand that I say no. For us today, a reorientation of that acetabulum is the key, because every other operation creates additional problems. Even we see in some publication good results, but I will have 99% of good results and not only 50%. You will never go in an airplane when you will have 50% of possibility of crash. No, you will never go in an airplane. No, the goal must be complication rate less. That means complication means redislocation and AVN and more, residual hip dysplasia, less than 3%, and not 20 and 30%. So, DECA is not a bad operation. The problem of all these kind of operation is the same. These operations are made with a wrong indication. Every operation have its own correct indication. Perhaps a DECA or Pemberton, I perform this in combination perhaps with a triple. The DECA and Pemberton osteotomy decreases the radius of the acetabulum, but needs a concentric hip. Otherwise, you create too much lateralization and pressure. Salter creates too much lateralization to high pressure. Therefore, if you read Salter's publication, he did never a Salter osteotomy himself by a failure of more than 20 or 15 degrees angle of the acetabulum, and not for a dislocated hip. DECA is the same. Augmentation is a problem, you know. We do augmentation never creates a good cartilage. So the key today is the reorientation, and this is the way to avoid also femur shortening. You don't need femur shortening the rotation, because in a triple, then you get the congruency in a normal way. I showed this 100 times, and nobody believes this. But if you go for DECA or all these two-dimensional or one-dimensional osteotomies, you have to address also the femur, because the femur goes down in a wrong direction. So again, in this age group, we start with triple osteotomy around 3 years of age. And therefore, if a child is 2 year, high dislocation, I say to parents, wait 2 years more, then the skeleton is a little bit more mature, and then we make a reduction and a triple. Between 2 and 3, 4 and 5, this is no disadvantage for the hip. No disadvantage. But it is a disadvantage when you make with 3 years a wrong operation, as you have seen before. You know, this is a disaster. Okay. Another question.
Dr. Usachen?
Yes, we have some questions, Dr. Longo, about capsulotomy. I mean, when you like the details, for me, perhaps in the article is very clear the front of the capsule and attach completely the capsulotomy and then to close it. And there's a question about is there some tip to handle the inferior capsulotomy and how to close it? You detach it the whole 360 degrees of the capsule from the acetabular side, and then you close it over the head.
Absolutely. You know, I guess also in your country you have some pipe smokers, and the pipe smokers, they have the tobacco in a bag, and then you pull the bag together. You know, this is a tobacco bag, and this is the same technique. You know, and this is exactly what Colonna did not, or Haygrove could not do. This circumference, this attachment, because you can do this only by surgical hip dislocation. You know, you have experience with surgical dislocation, Sergio, as well, and then you see the whole acetabulum, and then, you know, you start above, you go around here, and then from here you go around here, and then the capsule is free, and then you bring it direct around the head in this way. You close from behind to go to the tip, and you close it this way, as in the drawings. No, you have to do this. Otherwise, you cannot handle the acetabulum, the femur in a free way inside. And again, if you make no shortening, then you have to go inside in this way, and you disrupt the capsule again. No, it's important that you can do this in this way, really without any contact, and then inside in this way. Okay, that is the first, and then you bring femur together.
Yeah, Dr. Slong, we have also a question about the reamers. Is there a guide for reaming? Do you your guide for the size of the reamer? Do you take columns or the walls, the anterior posterior walls what's your anatomical references for that?
Yeah, that's a good question. Now, first of all, the size of the reamer you have in the set normally different sizes from the total hip, as you know it. You have not only one, and the size of the reamer depends a little bit on the size of the head. But you have to take in mind or in consideration that later on you have not only the head, you have around the head also the capsule. So it's better to make it a little bit bigger. And then according that direction, normally you have a very thin bone at this level of the acetabulum because it was never pressure to the acetabulum. So the bone has a resorption. So in this way, you have to go a little bit, not in an anatomical way like in a total hip. You go a little bit more upwards where you have better bones. And this is the reason why the acetabulum is then very short and you need the augmentation in addition, because the roof acetabulum, because you go a little bit more upwards, that means you go not in this way, then you have an acetabulum with a very short, and therefore you need the augmentation here. If you go in this way, then you will go through the through the bone. So this is the way to do.
Perfect. We have also a question about the graft, the bone graft. Do you put first the graft and then you ream, or you start reaming with the small sizes and then you put the graft and then you continue reaming? What's your technique?
Yeah, exactly. This is also a very good technical question. No, first reaming, then you see a good form of the acetabulum. Then and the roof of the acetabulum must be horizontal. That is mandatory. Not in this way, this plastic, horizontal. That means you have to ream in this way that you make a horizontal part at least. And then reduction, because when you make augmentation before reduction, then you get again a problem to go around augmentation, and then you can crutch the capsule away from the head. Therefore, make this in this situation around, and then the augmentation, and you bring the augmentation to the capsule, to the capsule, down to the capsule, that we have really contact to the capsule. Again, it's like the effect of the capsule is the same as in a Chiari osteotomy or any augmentation, because we have a not hyaline cartilage, it's still fibrous cartilage, and therefore it's allowed to make augmentation. But step one, reaming, shortening a short plate, shortening a closer, shortening, reduction, augmentation.
There's another question about is there sometimes have you used or thought about using like an augmentation of the capsule with the question here is about Achilles tendon for an allograft with Achilles, or allograft of something, facial Achilles or something, to reach the whole like coverage of the head?
Yeah, this is also a very important question. We try to do this in pre-operated cases with scars. So the capsule is in this situation, when you may go for open reduction, perhaps before, then you make a capsulorrhaphy or something like this, and then the capsule is not elongated as before, and then you cannot make the same operation, and then you cannot close the capsule. But the secret is that, as you have seen, the capsule is always attached to the periosteum on the femur side. That means the capsule is not, it has no avascular situation. The capsule has still, from the femur side, from the femur periosteum, some blood supply. If you bring in fascia or tendon to cover or to close open part, then this is death material, and we made not good experience. So in a situation you had previous operations, I guess we have to go more than for head reduction, a osteotomy, make the head smaller and triple or something like this, and augmentation, but not a capsular arthroplasty. Again, I would recommend to do this only in a fresh, untouched case, and then you have always, the capsule is long enough that you can close it.
Perfect, Dr. Sloan. There's also a question about after you reduce it, and have you ever thought about using like arrows, bone arrows, or something to attach again the capsule to the acetabulum? Have you needed to attach like arrows or something to bone to the bone and then to the capsule again, or not?
Then
just with the bone, just with the
But sorry, this colleague who puts this question did not completely understand the technique. You know, as you have seen in my animation, the capsule is disattached from the acetabulum, is only attached to the femur, and then we close it. So it is not possible after a reduction to give anchors or something, sutures from inside to the acetabulum to fix the capsule against the acetabulum. It's no longer important. And along the ream, it makes no sense. No, you have the capsule and then it goes in together. We never have seen a problem with this. No, it's not possible.
Yeah. We have also a question about the size of the reamers. Sometimes in Colombia you have, when you ask for reamers, sometimes reamers come from, I mean,
outside.
40 to bigger sizes.
Yeah.
In your article, you write something about 36. We have one or two like commercial factories that they brought us the reamers from 36. Is there like a standard or a more frequent size of reamer you prefer? I mean, you recommend to begin with 36 or 40 or less than 36 because we don't have less than 34, I think, reamers in Colombia.
Yeah, this is also a very important technical question. If you will start with such an operation, you must be sure that you have, or the company you give you the instruments from outside, that they are able to give you the correct instruments. And you have to check this before the operation. And these are the reamers for these plastic hips. In the set of reamers, there are the standard reamers for big adult hips, but there are also reamers for adult dysplastic hips, small hips. And I and Professor Gans recommend to start with the smallest one you have, because you have a shallow, not existing acetabulum, and then you take a too big reamer, you destroy all the bone here. No, it's better to have first a small hole and you enlarge it. You go from small to bigger, bigger, bigger until you have a really good coverage or bone. If you start too big, then you have a shallow acetabulum, and the acetabulum is then bigger than the head, and then you have an unstable situation. No, try to start with the smallest one. It's the same if you make at home as a hobby. You will drill a hole in stainless steel, and you have to make a hole of 1 centimeter. Then you start first with a drill of 4 millimeter or 5 millimeter, and then you take the bigger one, and not start with the big one. Yeah, no, it's much easier, much easier.
Yeah, absolutely clear, Dr. Slongo. Thank you. I don't see any more questions here, and I think if you have a second conference, I don't know, Sergio, if you agree, we can go to the next conference.
Yeah. Okay.
Yes, absolutely. Awesome discussion. We have a lot of questions and also a lot of good comments.
But we can at the end. Okay. Can you give me the screen free that I can open it? Okay. You can see it? Okay. Oh, sorry. This is the wrong one. So sorry, it's okay now. Okay.
Yeah, it's okay. We see now the femoral head reduction osteotomy for spherical deformities. Is the
Okay.
that's
So
okay.
so this is the next talk about the femur head, the problem in the femur head and in the hip. And again, also here, it's important. It's absolutely important that we, before we thinking about such an operation, that we are able to analyze a hip in a good way. So here, okay, uh, let me, perhaps I can do this here. I need perhaps this. Okay. So I guess today the most frequent indication for such an operation is given by the sequela of a pertus. We have some other cases as well, but I guess pertus makes, or the sequela of a pertus, even in adults, makes 90% or 92%. Okay, okay. So therefore, we have to focus a little bit our view on the pertus. So here you can read it. This is also a picture I got from your continent. Some years ago, I got this X-ray with this question. Again, I'm coming from a little houses for help. It's a 12-year-old girl. You can read it. Okay, it was on, and there was a question: what to do? What is the diagnosis? And did we need, or do we need more? So I will show the case again later on. So what is the problem of this hip? This is the question. You know, and you see the question is always first what we have to do, what we have to do. No, first of all, I will ask you what is the problem, what you can see here on a simple X-ray. So you know a normal hip is always spheric, the head is spheric, that's the double is spheric, and concentric. And what we see here is this. So something is wrong, and it's clear for me what is wrong. I don't need any other X-ray or CT scan or whatever. For me, the situation is clear. Okay, so what is then the goal in principle? And this, therefore, we make this operation. The goal of every hip therapy in pertus is avoiding secondary damages, preservation of the containment, preservation of the sphericity of the femoral head in the acetabulum, then to guarantee the function for the hip for a long time, and to reduce the long-term damages. So this is the goal. But when we are coming too late with our operation, then and we try to go for an operation at this late time, the goals remain the same, of course. So first of all, when you go to the internet, it's unbelievable what nonsense is written in the internet. I have seen nearly 100 articles or drawings in the internet about pertus and femur head supply and, but 99% are wrong, completely wrong. And I'm so surprised that this is published in the internet or in textbooks. This is all wrong. Don't take this. Okay, this is correct. And when you compare perhaps this drawing here in this drawing of this here, compare with our studies, then you see this is completely different, because this is an anterior view, but the vessel comes from posterior and only this. Okay, so we have to know this. I will not go about Stuhlberg classification and all the problem of the pertus, but anyway, you know we have 5 classes. I personally, for clinical reasons, I go into 3 groups. That we can have at the end a normal hip joint or spherical head, but not completely congruent. But this gives good result. And this must be the goal. Green must be the goal of every therapy. 3 and 4, you see, is different. And then we have 5. We should absolutely avoid to get in 5. So when we look pictures, what this means, these 3 groups is group 1 and 2, spherical congruence, as you see here, is this. This is spherical congruence, okay? Then we have the 4 It's not spherical because it's flat here, as you can see. And then, of course, this is the disaster. For femoral head reduction, this type here is, of course, an absolute indication. But today, we start also here because you never get a round head. So also this situation, we start to make it. So this and this. The goal is that we have at the end such a good range of motion, but we must be critical. Normally, I get such picture and said, absolutely normal. This is not absolutely normal. In external rotation, as you can see, is nearly symmetrical. But here, you see, it's a little bit tilt, and here is less than here. So, but it's a good range of motion. Even here, you see, it's not absolutely symmetric, but it's a good range of motion, of course. So that therefore is when we need therapy, in an early stage or late, if we lose the containment or the hip isn't centered anymore. That means such a hip, as you can see here, this is a good indication for such an operation. So the containment is the big word. Aspheric hinging hips, that means today a hinging hip is really good indication. And if I go back again for you, this must be a hinging hip because this is the hinging point here, you know. So this hip goes never in. Okay, good. The great word is containment. Then we had some head at risk signs. I will not go on these details because it's only a basics. So the next question is how we can achieve these goals. Can we achieve these goals in such a hip conservative or surgically? What means conservative? Wait and see? No, this is mostly insufficient. So operative options. There are different options today, and the classic intertrochanteric osteotomy, triple osteotomy can help in an early stage. Intertrochanteric triple and triple, good. But today, the keyword and the good view is that surgical hip dislocation in such problematic hips is the hip dislocation and head reduction. Okay, have a look. This is a typical example. At the first consultation here, looks not bad, but when you are critical, you see a flat head, type 4. We see that the hip is a little bit out, and we see that this is a little bit interrupted. So it's not critical, and as long we can go in abduction, there is no hip. So you see here now it looks quite nice. It looks quite nice here. So we can go and wait in this situation. But in this situation, they performed an intertrochanteric osteotomy. And you see now, when you see in the arthrogram, even we made the intertrochanteric osteotomy, this part of the head is still out. But we have now a wrong situation here. We have a we have a hanging head. Okay, I don't like this anymore. Still a problem in this situation. So with the triple, sometimes you can solve this problem much better. Why we can solve this much better? Because the fragment is free and we can bring this over the head, so we have no hinging. So this is a similar case, and with the triple, you see now here very nicely everything is covered very well. So in this early stage, a triple is okay. But what's about this case? You know, here we have a real problem. Again, at this stage, we have again this problem here. So wait and see in this situation is problematic. Abduction view, but this is not an abduction view, it's a frog view, gives no good result or answer. Only the abduction view. If we can go for triple or more. So here they were waiting, and then this was not good. So I will show you the new view and the new approach. So this was this hip. We performed surgical hip dislocation in this purpose. And this was the head, completely destroyed. Nobody ever had seen such a situation before because nobody up to us did make a surgical hip dislocation. And you see an empty head, but even in our hand, we could solve the problem. From the greater trochanter, we brought a part of the femur head into the here as a graft, and we closed, you see, and now we have really a very spherical head. But this is high surgery and we end up in a good result. Here again, a case treated with intratracheal osteotomy. Triple would be much better in this case. And then he end up in this, you see, dislocation, hinging problem here. So this is bad. And then we go for the MRI, we see really the problem of this hinging hip here. Okay, you cannot solve this problem in this way. So here you can do two things, splitting of the head or relative lengthening of the neck. We did relative lengthening and now the hip is inside, you see. You see now the difference here is much smaller than we had it here. Okay, good. So again, triple can do this as well, but sometimes you can make too much, and here we have also created a problem. This patient has a problem, as you can see here, and as you can see here in the MRI, extra-articular impingement. So we make a surgical hip dislocation, and we saw this, a double head. This is one head, this is the original head, and we have a double head here, and this is the line of the hinging, you see? So this hip has a problem, again, problem, hinging, head. So here, femoral neck lengthening could solve the problem, as you see here. Now, there's a big distance now here before we had extra-articular impingement here. So, this is the relative lengthening in the way. How we do this? In this way, remove it, and then this. Okay, look at this hip. Again, some subluxation, old case. MRI shows the problem here at the tabulum and shows the problem here. So what we can do here? Of course, we go for surgical hip dislocation. And this is the case. This is a necrosis of the central part of the head, of course. And you look, the destroyed acetabulum or the labrum. And here again, we took bone graft from the greater trochanter. We made the debridement, and where we could take the cartilage, we took the cartilage from here and brought it to here with special anchors. We fix it outside, labrum repair, and then you see a fantastic healing of this head. This was before, this is today, and this is after some years. You see a spheric head, fantastic situation, and even 3 years post-operative, we have a good situation. So we could repair all by opening of the surgery. So what is the problem here? Again, it starts here with this problem here. And then the people are waiting too long sometimes, and then it goes in this way, and now you see we have the central part destroyed. We have healthy bone here, extra-articular, so this is the problem. So how to solve this? Now we came to this operation, as we'll show you. Surgical hip dislocation is again the key. This is the head. You can say, oh, this head looks not bad, but you see this part here is necrotic. This part here is necrotic, but the cartilage is still good. You remember the case before. When you are waiting too long, we will have a rupture of the cartilage, and then everything is over. So here then, we cut it by, here you need also, the reticular flap technique is published to get a free head. Then we cut away, we plan to cut away this part of the head, as you can see here, and we removed it. You see the bad cartilage, exactly like we published. And now here, you see, here is a good bone contact to the cartilage, healthy cartilage, here as well, good bleeding. And then we bring this part, we bring this part to here, as you can see it here. And here you see this part, and this is the gauge sign here. You see extra artery. This makes the hinging. And you see, even you do not this operation, but you open the hip and you make the debridement of the desk bone, the healing is much faster. BMP, as some people propagate, cannot help because this is a death area, no blood supply, nothing. You see? Okay, and then we bring it together, and it is in this way. And now you see, in this situation, it fits. We have a good situation, it fits. Sometimes if the acetabulum is not as good as here, but even here we have a double acetabulum, you see double, but it fits well, you can do this. And this was before and after operation, and this you see the healing, good coverage, everything is okay, and movement here in this patient is nearly perfect. But sometimes, as you can see here started, it's not so perfect as before. We need then sometimes an additional triple osteotomy in this situation. Now, this is the older patient, as you can see here. Hello? Older patient. And you see the problem, hinging hip. The cartilage looks not so good as before, but even here we can do this operation. But here, you see, later on, we performed a PIO to coverage this. And here now you see the fantastic result. Here now in the animation, the situation, you see this is the pathological part. Here, normally we have the acetabulum here. Okay, then you see the retinaculums, the muscle, and this is the death part of the bone, as you can see in the dotted line. So this is the preparation. So you see, you prepare all this part here together with the on this part, the vessel on this part, as well you prepare this on this. So both parts have blood supply, so we can remove this. You see, it's removed in this here with some bone. Then we bring it together in front. You see, so the blood supply is given here and here, and the inside-out technique to prepare this is seen in our publication here on this side. And then you see the blood vessels, as you can see here, are still here over the retinaculum, still here, here, and here, and then relative neck lengthening. So coming back to the case at the beginning, now you can understand much better the pathology of this hip. I believe this hip would be exactly the hip as we have seen here. This would be this hip here, and I know this, and here today with this I would perform also a resection of this part and bring it in. But as you can see in this situation, the MRI looks not so bad. But when you make the surgical hip dislocation, you see this bad hip. And in this situation, of course, you can do nothing. Sometimes it's really too late. And in this situation, then we go for arthrodesis. So in conclusion, especially the Pertus disease has clearly many aspects, so that probably the concept of a family of disease we speak. And Pertus is a kind of a family disease. The example of different treatment which I have shown demonstrate the applicability of this philosophy. Stable hip don't need a treatment at all. Intertrochanteric osteopathy, like also triple, can cause an impingement, as you have seen in another example. A single treatment modality is probably always not sufficient. Thank you for your attention.
Well, thank you very much, Dr. Longo. I think that we have here some questions. It was an awesome presentation. Thank you very much, with very good cases, and I think that all of us enjoy it. Dr. Usecha, are you ready for questions?
Sí, Sergio, tengo un problema con la cámara. Denme un segundo, si quiere vaya dándole a las preguntas. Gracias.
The first question, Dr. Slongo, is about the youngest age that you have done close reduction head osteotomy.
The youngest case, I guess, was around 9 or 10 years of life, because a very early pertus neglect, then the typical lateralization, then the hinging, and the abduction U showed that we have not a reduction of the head. If we get a reduction of the head in this age group, 8, 9, 10, then we go for triple, of course, as I have shown before. But if you get not a reduction or in abduction U, and again, sorry to say this, but in the majority of the countries around the world, especially also from your continent, when I am asking for a correct abduction view, I get always a frog view. The frog view is for nothing. It's only waste money. A correct abduction view is abduction in supine position, internal rotation of the foot of the 30 degrees, and abduction as possible as it is, and not frog view. So you have to learn and to teach your radiologists, the department, to do this in a correct way. I see this in China, I see this in your continent, I see this in USA. So that means again, if the abduction view shows a concentric hip, I will go for triple in age 9, 10. If I get not, I get a hinging, that means it hinges, and hinging means is no rotation. Hinging means this, huh? This is hinging. Then we go for height reduction. Because again, there are some colleagues, they say, oh, Dr. Slongo, with 10 years, you destroyed the growth plate and everything. You must know, in a pertus, such a severe pertus, the growth plate of the femoral head is anyway not working. You know this, huh? It's not working. The greater trochanter has an overgrowth. So we get in this relative varus. What you prefer? To have a concentric good hip with some shortening of the leg, perhaps of 1 centimeter or so, or to have a steep, bad hip. What do you prefer? You know, this is a clear answer. I prefer to have a normal hip. No, this is also an old, wrong historical meaning and approach about the growing of the proximal femur. The physis of the femoral head, as well of the greater trochanter, you remember, was a unique physis at birth. We need this physis to see it in the ultrasound. And during the life, in the first 3, 4, 5 years, we get a separation of these two physes. But even later on, the trochanter physis is communicating with the head physis. And these two physes are not responsible for the lengthening of the femoral neck. No, they communicate only to keep the anteversion angle and the C angle, the neck shaft angle in a correct position. It's like in the distal humerus. Okay.
Thank you, Dr. Slongo. We have also a question about if you sometimes, what's your opinion about valgization and antitrochanteric osteotomy to change like the
again
the orientation of the
I understand. I have seen this, and 30 years ago, I guess, once, twice, we made it as well. Again, I try to communicate, try to analyze the problem. And you know, if you have a subluxated femur in a pertus, why to make an additional valgization or rotation? No, the key is the containment. And then, as long as you get, again, in abduction, you get the reduction. That means even the hip is like this, but in abduction and not in frog view, the hip is in, then okay, you go back and you go for a triple. It's much better. Then you are press free, pression free. You know, this is the key and the secret of the triple osteotomy, even in dislocated hips. In a triple osteotomy, the acetabular fragment is free and goes spontaneously, goes around the head in a good way. You have nothing to do. It goes around the head, you know, without any forces. And then you have a correct position. So therefore, all these additional small operations, they are a try to make things better without a clear understanding of the biomechanics. And I know and I understand this very well. If in your hand, this high-end surgery, you are not familiar with this, you try to solve the problem with a simple solution. But then I explain this always like as in Colombia, you have high mountains, we have high mountains in Switzerland. But if you climb up on a mountains, you know, with the wrong equipment and the wrong route, you will fail. You know, therefore, 40 years ago, they tried to climb up some famous mountain in your country, but they died because of the bad equipment. But today, this is strange for me. Everybody who is listening this lecture has sure a smartphone, Apple or Galaxy or whatever, you know, and normally he changed the smartphone every 2 or 1 year because of the new generation. But in surgery or hip surgery, you are still working with equipment and IDs and payment of 40 years ago. This is strange. But in the meantime, we made an evolution and we have new approaches and we have new knowledge and we have new techniques. But the surgeon still is using the old fashion. Therefore, I say always the surgeon is one of the most conservative people in the world. He's so conservative.
Thank
Do you
you. Very
understand my
clear.
message?
Yes, sir. We understood very clear. We understand the power of the reduction osteoblastics, but not the intertrochanteric osteotomies, the traditional intertrochanteric osteotomies. We have another question, Dr. Solango. Yes?
Yeah, again, we make a lot of intertrochanteric osteotomies. But when I do it, when I have a real, nearly singular problem on the femur side, in a normal acetabulum, you know, like a high valgus or rotational failures or a varus and then in a valgus. But this is then a particular problem of the femur. But here in that what we are discussing here, in this pathology of the femoral head, later on as a sequela also of the acetabulum, we have to go in another way, you know, because these is going together. This is my message.
Yeah, this is very clear. Thank you very much. We have two more questions and then we continue with Dr. Nosa. Have you ever had the need to repeat the reduction osteoplasty? I mean, have you ever done it twice or something like that?
Never. No.
Okay.
I can tell you, and we have no fail up to now. We had never seen in the head reduction as in the colonna. We had never seen an AVN. We had never seen a redislocation. In September, a publication came out about Pertus, but is in a German journal. But I have I wrote the article about head reduction with all these drawings you have seen before. But I made more drawings, and I guess even you cannot read all this in German. The abstract is in English, but you see the drawings, and with Google perhaps you can also translate the most important things of this article. And I would recommend to read this article. Is a technical article, step by step, you know, step by step, how to do this reduction, you know, and therefore I recommend this. It's published by Springer, and the journal is OOT, Operative Orthopedics and Trauma, and came out in September.
Thank you for that reference. Dr. Longo, have you ever had the experience to use hematopoietic cells or growth factors to
Sorry, Luis. Sorry, Luis. You had
during this cancer surgery?
Can you repeat it, because your voice was not complete? Can you repeat it?
Yeah, there's a question about using growth factors or hematopoietic cells, mesenchymal cells, for improving the results. Have you ever
No, this is for me. Of course, when these products came out, okay, I was using this once or twice without any effect, and it's so expensive. And once you have seen my picture with the necrotic zone, can you explain me how these factors can work without blood supply and nothing in this necrotic part? No, it's not possible. Therefore, a good debridement is much better, because then I have a good bone circulation. Okay, no, I never used it over the last 20 years, never. Okay.
Okay, thank you, Dr. Slongo. The last question is about the template. I remember you had when I was in Switzerland for when you work with a template to measure the circumference of the head. There's do you still use this template, this plastic template? Do you use it for the reduction of the plastic?
This is the same template we are using for impingement and cam for the cam lesion reduction. These are the typical, I guess, every orthopedic surgeon who is dealing with total hip or replacement has this template, I guess. This plastic is very cheap. It's very cheap, plastic template. Now it's very helpful, and especially for the head reduction. Perfect.
Thank you, Dr.
Only a short comment. In the meantime, I said before, we normally never use a CT scan or something like this. But now, in the meantime, only for experiments, it does not help so much in the clinical situation. We have a program together with the Balgris Clinic you mentioned before in Zurich, for 3D reconstruction, not to print it out, only a virtual program, so that we have the normal side, and then we project this on the pathological side, and then we see that these two parts are not together, and the computer calculates which part of the head you have to resect to get the best result, like on the other side. But this is only based on the bone, but it's not based on the vascularity. Therefore, it's a fantastic tool to do this. I have not shown pictures because you are not able to do this, but it's theoretical, very helpful, but in practice, it does not help, because when the computer says you have to go in this way, but you cannot go in this way because of the vessels, and you create an AVN, you have to make a compromise. So only for scientific situation, it's very helpful. This is the chart planning, CARD. CRRD. Okay. We do this with the Balgrist.
Yeah. Dr. Slongo, have you ever changed the orientation of the reduction osteotomy? Have you ever tried like an oblique one, or not a sagittal, but also a coronal one? Because when you do a coronal, you have the whole vascular supply in the posterior side, so it's logical to change sometimes. Have you ever tried an L cut?
No, not. because it's too dangerous, and I would not recommend this. And on the other hand, again, you have to see the biomechanics, even in a purchase, and you see this when you make X-ray in sequela in all the purchase. You see in the AP view, perhaps you have a flat head and then a long head. But in the axial view, then you see a quite spherical head. That means because the patient normally moves in flexion and extension in a normal way, but the hip tries to go outside, that means in this view, you have this situation, In this view, you have a quite good head form, but not in this view. So therefore, in the most situation, you have to cut the head in this way or a little bit oblique. Dror Paley copied our osteotomy and has published this, and now he is always speaking from Ganz type 1 or 2. This is so stupid for me. I discussed this with him, really, to say this, but this makes no sense. First of all, the cut or the direction of your resection is limited, as you say, by the vascularity. It's limited by the vascularity. You cannot go in every direction. It's limited. So you have to go by some compromise, of course. And then you have to look what is the best. No.
Thank you. Okay, thank you, Dr. Slongo.
Yeah.
Dr. Nosa, we are getting short of time. So Dr. Nosa, I'm sorry, we have taken some of your time. So please go ahead with your presentation, please.
Thank you very much, but no worries at all. I think that we are all here to learn from Dr. Slongo, so it is perfectly fine. No worry at all. So, Dr. Slongo, sorry, I will talk in Spanish.
No problem. I like it.
Muy bien, buen día para todos, mil gracias por acompañarnos, es realmente un absoluto placer aprender del doctor Slongo y vamos a contarles un poco sobre lo que en el instituto pues hemos tenido de experiencia sobre artroplastia por interposición o la técnica de columna. Esos son mis conflictos de interés que son obligatorios para todas las presentaciones y vamos entonces con los objetivos de esta presentación. El primero de ellos es que queremos aprender que nosotros realizamos una técnica modificada, un poco diferente y pues estamos aquí precisamente para discutirla. Y también queremos pues mostrar un poco nuestros resultados y compararnos, ¿por qué no?, con los mejores y pues creemos que en este caso nuestro estándar de oro sería posiblemente la escuela suiza. Esta entonces es mi primera paciente. Voy a comentarles entonces la historia. Una niña con síndrome de Down, fantástica, con 30 meses, con una luxación de la cadera no reductible inicialmente y pues nosotros realizamos osteotomías femorales en los pacientes que tienen alteraciones grandes de la versión, como fue esta paciente, y decidimos llevarle a un CLISIC. Nos fue muy bien, afortunadamente, con la cirugía de CLISIC, y que pues de pronto para el doctor Slongo y para las personas que no nos acompañan desde Colombia es la reducción abierta de la cadera acompañada de una osteotomía femoral de acortamiento y una osteotomía pélvica. Ahora con 5 años estaba muy bien, con muy buena evolución, muy buena movilidad, como es frecuente en Down. Digamos que teníamos un poco tal vez de necrosis acetabular con un poco de irregularidad de ese nivel, pero en términos generales se veía muy bien y decidimos retirar la placa. Sin embargo, después de retirar la placa, a la semana tuvo una fractura la paciente. Y esa fractura de fémur pues, nos llevó a que le hiciéramos una reducción abierta con unos TENS y todo iba bien. Sin embargo, 3 meses después de la osteosíntesis, la paciente empezó a cojear y se presentó con esta radiografía. No entendíamos por qué realmente se había luxado, si aparentemente la versión femoral estaba bien después de la fractura. Sin embargo, en ese momento pues decidimos programarla para un nuevo CLISIC. Se demoró un tiempo en poder programarse efectivamente la cirugía y a los 7 años nos encontramos con este panorama. Y es aquí donde empezamos a pensar en qué hacer con estos pacientes. Lo que ustedes ven ahí es una cabeza femoral completamente denudada de cartílago. Y entonces, pues no estábamos preparados para esto. En principio es una paciente que tuvo una luxación hace poco tiempo. Además, realmente era la mejor paciente del mundo con una familia fantástica. ¿Y qué hacemos entonces en ese momento? Pues podíamos seguir el plan inicial, podíamos parar en ese momento y buscar enviársela a otra persona que de pronto tuviese más experiencia en este tipo de reconstrucciones, parar y proponer otra salida para el paciente como como desactivar la cadera de alguna forma, como un McHale o un soporte pélvico, o la otra opción pues era por supuesto sentarnos a llorar. ¿Cuál es el problema entonces del cual estamos hablando aquí? El problema del cual estamos hablando es que tenemos defectos condrales mayores y también tenemos pues caderas que en ese orden de ideas son irreparables. Ustedes ven ahí 3 fotos de los pacientes que les voy a comentar el día de hoy con unos defectos condrales en la cabeza femoral pues muy importantes. ¿Qué dicen los maestros sobre colon? Ahí ustedes ven una foto de hace algunos años cuando tuve el placer de aprender del doctor Slongo y lo primero que nos dicen en la mayoría de trabajos y pues de hecho también algunas personas que hacen preservación como por ejemplo el doctor Useche están de acuerdo en que es una mala idea pensar en colona si la cabeza femoral está dañada. ¿Qué quiere decir que está dañada? Que tenga una mala forma o que tenga un daño en el cartílago. Sin embargo, pues básicamente esos son la mayoría de nuestros pacientes. ¿Por qué? Porque a esos pacientes les va peor, tienen rigidez, que es la principal complicación en la literatura, y además de tener rigidez, pues también digamos que tienen unas tasas de sobrevida de sus caderas pues muy baja y en ese orden de ideas tal vez no valdría la pena intentarlo. Pero entonces, si decimos que es una mala idea pensar en colona para estos pacientes, ¿qué otras opciones tenemos? Podemos dejarlos en un Girlestone, podemos hacer osteotomías valguizantes que desfuncionalicen la cadera, como un McHale, podemos pensar en un soporte pélvico, en una artrodesis o un CLISIC convencional. Es decir, olvidarnos de que esa cabeza femoral está dañada y simplemente meterla al acetábulo y esperar a ver qué pasa con ella. Entonces, cuando uno tiene pues esas opciones que tampoco son tan buenas para los pacientes, pues resulta que la opción menos mala puede ser nuestra mejor opción. Estamos finalmente ante una cirugía que es una cirugía de salvamento y pues no esperamos necesariamente resultados maravillosos para estos pacientes, sino esperamos unos resultados modestos relacionados con esto. Entonces, vienen 2 preguntas adicionales. La primera es si debemos o no fresar el acetábulo y la segunda pregunta es si debemos retirar o no uno de los estabilizadores más importantes en un CLISIC, que es la cápsula del paciente. Entonces, y también pues resulta que nuestros pacientes son un poco más pequeños, sin embargo ya nos mostró el doctor Slongo que pues que es muy importante, inclusive en pacientes pequeños, pensar en esperar un poco hasta que estén en la edad adecuada para pensar en un colon. Entonces, ¿qué modificaciones fue la que hicimos esa primera vez? No hicimos un fresado acetabular y no utilizamos la cápsula como un elemento de interposición. Hicimos osteotomías pélvicas y utilizamos la fascia lata como elemento de interposición en nuestro primer caso. ¿Por qué? Pues básicamente creo que fue por miedo de que nuestro paciente se fuese a inestabilizar por utilizar la cápsula, teniendo en cuenta que además era una paciente con un síndrome de Down. ¿Y por qué no hacer el fresado acetabular? Pues en primer lugar, ese día no estábamos preparados para eso, y en segundo lugar, si el acetábulo no está tan dañado y creemos que le podemos dar una forma razonable con una osteotomía pélvica, pues sigo creyendo, estoy dispuesto a aprender que es una buena idea pensar igual en hacerlo para estos pacientes. ¿Qué dice la literatura? Se han utilizado un montón de tejidos diferentes a la cápsula. Dentro de ellos, digamos que hay 2 reportes grandes, uno con fascia lata publicado en el BMJ en el 2019 por el doctor Patricio Espinosa, y otro de aloinjerto térmico descelularizado por el doctor Matthew Sloan. Entonces, pues digamos que se han utilizado otras cosas diferentes a la cápsula y nosotros pues también utilizamos algo diferente a la cápsula. ¿Qué modificación le hacemos a la técnica original? Pues que tomamos el injerto de la fascia lata y después de eso lo vamos suturando progresivamente alrededor de la cabeza femoral. El abordaje que nosotros hacemos es nuestro abordaje convencional para una luxación de cadera, un Smith-Peterson modificado anterior ampliado para poder tener una mejor exposición de la cápsula. Y lo que hacemos es una sutura progresiva del injerto de estos pacientes, como ustedes lo ven ahí. Este fue uno de nuestros primeros pacientes. Ustedes pueden ver en la imagen de arriba a la derecha la cápsula con algunas arrugas. Después aprendimos a las malas que pues era muy importante que el injerto quedara muy estable y muy bien adherido. Y entonces, por ejemplo, el paciente de abajo, ustedes pueden ver que es una cápsula mucho más lisa, con un contorno mucho mejor. No la cápsula, perdón, sino la fascia que colocamos centímetros sobre la cabeza femoral. Entonces, finalmente, la idea del doctor Colonna pues, era interponer la cápsula y buscar un tejido que funcione como un cartílago, que haga un tejido fibroso allí, que funcione como un tejido fibrocartilaginoso que nos pueda funcionar para mejorar la movilidad del paciente y para diferir la artrosis, que es lo que queremos, que estos pacientes lleguen a su reemplazo de cadera. Finalmente, no esperamos que no lleguen allá, pues lo más tardíamente posible. Entonces, hasta 1999 tuvimos muchos reportes de la cirugía de colona. Eso fue ya hace casi 25 años. Sin embargo, sale un trabajo del doctor Boardman donde dice que sugiere no revivir este procedimiento que ahora es oscuro, en el sentido que la mayoría de los pacientes pues tienen un mal resultado. Y en ese momento la mayoría de reportes sobre colona disminuyen rápidamente hasta que vuelve y aparece en el 2012 básicamente el estudio del doctor Slongo con el estudio de Gans. Si ustedes ven esta gráfica que en conjunto con la diapositiva siguiente incluye la mayoría, si no todos los trabajos que hay sobre cirugía de colona, lo que ustedes van a ver ahí es el autor principal, el año en el cual fue publicado, el número de caderas, que está aquí en la mitad, la edad de los pacientes y luego resultados malos, regulares, buenos o excelentes basados en diferentes escalas. Si ustedes ven, pues hay trabajos que muestran solo resultados malos, otros que muestran solo resultados buenos y excelentes y otros que están un poco como en la mitad con regulares y buenos. Fíjense el trabajo del doctor Gansi y el doctor Slongo, que es pues un trabajo que muestra 9 pacientes, que muestra resultados buenos y excelentes para todos sus pacientes con un seguimiento no menor a 2 años. Estos son resultados previos en la literatura. Ustedes ven ahí los resultados, por ejemplo, del doctor Laurent con 92 caderas con resultados buenos y excelentes hechos a pacientes de alrededor de 5 años. Es decir, había unos reportes muy alentadores en la literatura previamente. Sin embargo, con el tiempo se fueron cayendo y pues digamos que no han sido tan buenos en los últimos años. Si uno distribuye esos resultados puntuando por el número de caderas únicamente, pues nos damos cuenta que los resultados son muy dispares, es decir, no todos los resultados van hacia el grupo de buenos y excelentes, sino que tenemos como 2 picos de resultados, unos malos y otros buenos y excelentes. Digamos que grosso modo uno podría caer como en un tercio en cada uno de estos posibles grupos. Entonces tenemos en resumen malos resultados 27%, regulares 12%, lo cual nos da casi la mitad de los pacientes, 40% para malos y regulares, y buenos y excelentes el 60% restante. Es decir, que si uno va a caer en un grupo o en el otro, es cercano a lanzar una moneda en el aire, sin tener en cuenta, por supuesto, todas las consideraciones de las cuales nos habló el doctor Slongo previamente. ¿Cuál ha sido nuestra experiencia? Pues lo que les decía, nosotros iniciamos con una técnica diferente a la sugerida. La primera cirugía la hicimos y esperamos los resultados. No hicimos ninguna cirugía hasta que nuestra primera paciente completó 1 año de seguimiento, sin hacer fresado acetabular, haciendo osteotomías pélvicas y no haciendo injerto con la cápsula, sino con fascia lata. Y esta paciente pues tuvo un muy buen desenlace y hoy en día sigue con un muy buen desenlace. ¿Qué número de caderas tenemos nosotros? Tenemos 8 caderas y aquí entonces les traemos algunos casos para ambientar un poco la discusión. Este es nuestro primer paciente, esa fue la sutura capsular que le hicimos con ese resultado posoperatorio que ustedes ven ahí, con una osteotomía pélvica, un tipo acetabuloplastia. En nuestra cabeza disminuir el radio del acetábulo es muy importante, sin embargo pues también existe la opción por supuesto de reorientarlo cuando tenemos acetábulos de radio similar. Con ese resultado inmediato posoperatorio. Y luego aquí está la paciente, pues a los 8 años programada para su retiro de material de osteosíntesis con esta radiografía después del retiro y la vimos hace muy poco tiempo por videollamada 4 años después del retiro, es decir, 5 años después de la cirugía y la paciente y la madre están felices, tiene una muy buena movilidad, no tiene dolor, realiza una vida razonablemente normal, por supuesto teniendo en cuenta que esta paciente tiene un síndrome de Down. Nuestro segundo paciente fue un paciente mucho mayor, 19 años, con una parálisis cerebral, una clase funcional muy baja, una clase funcional 5 con una subluxación crónica. Sin embargo, un paciente que se ayudaba en sus traslados, un paciente muy grande, y por eso decidimos intentar realizarle algo diferente a desfuncionalizar la cadera. Sin embargo, este paciente pues tenía una lesión condral muy grande en su cabeza femoral, tenía una indentación en ese sitio donde el doctor Slongo nos mostró que se hacía la bisagra alrededor de la cadera y finalmente pues digamos que este paciente a los 16 meses meses posoperatorio, 1 año y medio después tenía una movilidad pues muy pobre, una extensión de 0 a 25 grados sin rotaciones, pero ese paciente mejoró su posicionamiento, no tenía dolor y podía seguir realizando las actividades con una familia que estaba muy agradecida con nosotros. Podía seguir haciéndose de estación y pues digamos que las pocas actividades que hacía las continuó haciendo sin ningún problema. Este paciente desafortunadamente falleció por un problema abdominal no relacionado con su cadera y pues perdimos su seguimiento, pero una familia que vivía muy lejos de Bogotá en un área rural y realmente el paciente después de la cirugía mejoró sensiblemente. Este fue nuestro tercer paciente, un paciente de 7 años, se le hizo un CLISI previo en la otra cadera a los 6 años. Este fue el posoperatorio inmediato donde se le hizo pues la cirugía de columna para su cadera derecha y esta paciente hizo una rigidez posoperatoria temprana muy importante. Le hicimos una movilización bajo anestesia general con la cual logramos una movilidad realmente no muy buena, además se hizo de una manera muy tardía también en buena parte por problemas administrativos y después de eso pues hizo una necrosis vascular adicional y quedó con esta movilidad pues muy pobre, ¿sí? Flexoextensión de 0 a 20 grados, no rotaciones, no abducción, aducción de 20 grados y una marcha en Trendelenburg que ya les vamos a mostrar aquí en conjunto con un signo de Trendelenburg pues que tenía la paciente. Sin embargo, pues aún con todo esto la paciente no presentaba dolor, ¿sí? Y pues aunque la otra cadera estaba mejor y funcionaba mejor, pues digamos que creo que para pacientes que tienen luxaciones tempranas, que fue la indicación original, no estoy tan seguro que sea la mejor opción realizar colona o el CLISI que nosotros hemos venido realizando toda la vida que nos da unos resultados razonables para estos pacientes. Este es nuestro cuarto paciente, un paciente de 10 años con una parálisis cerebral, una luxación paralítica de la cadera, con este resultado posoperatorio. Tuvo una lateralización temprana y aquí aprendimos algo también y es que el injerto tiene que quedar muy firme y no puede quedar apretado cuando entra la cadera. De lo contrario, el injerto puede rasgarse parcialmente y ser un obstáculo para tener una buena reducción del paciente. Entonces, este fue realmente pues un colona fallido, pero pues les contamos nuestra experiencia porque todos estamos aquí para aprender. Y es muy importante que el injerto quede atado firmemente a la cabeza femoral. De lo contrario, pues no funciona. A este paciente le retiramos el injerto, es decir, finalmente no quedó como un colona. Hizo una gran rigidez posoperatoria, ¿sí? Y a los 10 meses le hicimos una movilización bajo anestesia. Tuvo una fractura femoral no durante la movilización, pero sí durante la terapia consecuente a la segunda semana y le realizamos una osteotomía extensora simplemente para mejorar el posicionamiento. Este paciente también lo perdimos, último control más o menos al año de la cirugía, con una movilidad muy reducida de su cadera y pues tenemos en cuenta que es un colona fallido en el sentido en el que retiramos el tejido de interposición. Este es otro paciente también con una parálisis cerebral, una clase funcional 4, un paciente que se movía poco, pero pues ayudaba a sus traslados, también una paciente grande de 10 años con hipofosfatasia asociada con esa lesión condral severa que ustedes ven en la cabeza femoral. Le realizamos esta sutura capsular que en ese día nos quedó no tan bonita como me gustaría. Hoy en día utilizamos la cápsula más larga para tratar de que quede con la menor cantidad de suturas posibles y estamos utilizando además en vez de Vicril PS para disminuir la carga inflamatoria articular. Esta paciente, sin embargo, tenía movilidad muy razonable a los 2 años y en general, pues digamos que le fue muy bien. En resumen, entonces, tenemos 5 caderas con seguimiento mayor a 2 años. De estos, un paciente con rigidez, un manejo inicial de luxación de cadera, un paciente con una infección. Ese paciente que terminó en infección es un paciente que tenía una condrolisis severísima de su cabeza femoral sin una luxación. Le hicimos un abordaje de luxación controlada, le colocamos la artroplastia de la fascia lata y luego le colocamos un fijador externo. Esa paciente se infectó y terminó en un Kirleston y actualmente está esperando pues un reemplazo de cadera. Tuvimos 2 pacientes con una movilidad razonable y dolor leve, que los consideramos unos resultados buenos, teniendo en cuenta pues que no movían antes tampoco y que tienen una parálisis cerebral. Digamos que la mayoría de scores no aplican para estos pacientes y pues eran pacientes que se siguen ayudando en sus traslados con las familias que están contentas con la cirugía y una paciente con movilidad fantástica que es la que lleva 4 años con nosotros, que es la paciente del síndrome de Down, que está sin dolor y realmente lo está haciendo muy bien. Con respecto a la movilidad y el Harris, ustedes lo pueden ver ahí, unos resultados razonables, perdón. Y ustedes ven pues que la movilidad no es una movilidad impresionante, con una extensión de 10 grados, flexión de 88, muy pocas rotaciones, 27 y 15 grados. Sin embargo, pues una movilidad que, para tener en cuenta la severidad del daño de estas cabezas femorales que les hemos mostrado, pues me parece que es razonable. Los pacientes que tienen seguimiento menor a 2 años son 3 caderas. De estos, un paciente con una movilidad razonable, dolor leve, tiene una parálisis cerebral con una clase funcional 4. Un paciente con PC que fue el que falleció, que ya les mostramos. Y un paciente que falló, que también se los mostramos, que el injerto no quedó bien suturado y produjo una lateralización temprana, y por eso lo retiramos tempranamente. Entonces, en resumen, de nuestras 8 caderas, pues tuvimos en el primer caso, que fue excelente, que creo que fue el que nos dijo intenten hacer más casos, pero luego cuando empezamos a hacer más, pues nos dimos cuenta que los resultados no necesariamente eran tan buenos. Sin embargo, pues tenemos 2 casos malos, que uno es un fallido por infección y otro fallido por injerto perdido, que si hiciéramos unos criterios de exclusión diciendo pues que no aplicarían para continuar la técnica, pues nos dejarían básicamente muy alta nuestra puntuación. Sin embargo, siendo lo más honestos posibles, pues les contamos todo lo que ha pasado con nuestros pacientes. Y es que tuvimos un resultado excelente, 4 buenos, uno que está regular, que es un paciente que está rígido y con algo de dolor, y 2 resultados que francamente nos parecen malos. Uno de ellos que está en Girleston y otro que está pues muy rígido y que tiene dolor en este momento y está esperando una nueva cirugía. ¿Qué dice la literatura en general sobre la interposición? Pues que lo que se necesita es una superficie suave, lisa, que sea estable y que se debe transformar a tejido fibroso pues de algún tipo. Sin embargo, pues no tenemos tampoco ningún estudio que diga qué se puede y qué no se puede hacer necesariamente. Por supuesto que entendemos las contraindicaciones que nos sugiere la literatura. Sin embargo, este trabajo, que es un trabajo basado en las características biológicas básicamente de la interposición, aunque es un estudio hecho para miembro superior, pues para hombro, pues digamos que no se considera un pecado mortal realizar la cirugía cuando no estamos haciendo ni el fresado acetabular ni utilizando necesariamente la cápsula pues del paciente. Sin embargo, pues no hay estudios de ciencias básicas con esta técnica que nosotros sugerimos, ni siquiera sugerimos, porque creo que estamos lejos de poder sugerir con nuestros resultados qué es lo que se debe hacer, pero pues les cuento lo que hemos hecho con nuestros pacientes. Y entonces, pues digamos que si la literatura en ciencias básicas no se opone y pues consideramos que es la mejor opción dentro de las malas que tenemos y que sigue siendo una cirugía de salvamento, pues seguimos creyendo que es una opción válida para tratar estos pacientes, y estamos aquí, por supuesto, para aprender de los grandes maestros como el doctor Slongo, para que nos den sus luces para poder continuar con este camino de las caderas que no deberían presentarse, que son las caderas luxadas, inveteradas, y que si realizamos mejores tratamientos tempranos o mejores pesquisas o mejores tamizados, pues deberían dejar de suceder. ¿Qué más les contamos de nuestra experiencia? Que pues la edad inicial de nuestros pacientes fue alrededor de 12.8 años. En este momento tenemos un seguimiento promedio de 2 años y medio. Nuestros resultados son similares a los de la literatura global, no a los de la literatura específica, es decir, no están pues de la mano, por ejemplo, de los resultados del grupo suizo, que todos los pacientes estaban excelentes y buenos. Nosotros tuvimos resultados malos y regulares también. No se parecen nuestros resultados al trabajo del INSEL, también pues es una técnica diferente. Sin embargo, si sacáramos a los 2 pacientes que tuvieron colonas fallidos, al infectado y al que le retiramos el injerto temprano, nos quedaríamos con la gran mayoría de pacientes entre buenos y excelentes y pues un regular. Como conclusiones, entonces, pues nuestros resultados con la modificación a la técnica original son similares a los de la literatura general, y creo que si hay pacientes con criterios para la técnica original, pues debemos intentar volver a ella, y creo que este tipo de actividades nos hacen querer volver a intentarlo y volver a buscar pacientes que sean candidatos a la técnica, que estoy seguro que los tenemos. Y para mí, pues sigue siendo una cirugía de salvamento con resultados consecuentes de salvamento. Yo no espero que estos pacientes nunca en su vida vayan a llegar a un reemplazo, espero simplemente darles una calidad de vida razonable mientras llegan al momento ideal para realizar una artroplastia como un reemplazo articular. Queremos una vez más ponerles de la mano al servicio de ortopedia del Instituto Roosevelt, del cual trabaja de la mano absolutamente la Javeriana. Ahora, además de eso, tenemos la oportunidad de ser un Fellow AO para ortopedia infantil, y pues estamos aquí para el servicio de ustedes. Muchas gracias. No sé, doctor Useche, si tenemos alguna pregunta del auditorio o no sé si, I don't know if Dr. Longo, did you want to tell us something? I know that it is not the standard technique, but I show you our cases.
I guess I have 2, 3 comments. First of all, congratulations. And the second point is, I was speaking, and we focus really for the colonna on untouched neglect hips. In your case are mostly have some previous treatment, and therefore, what we discussed before, of course, in every case who had an open reduction or tried to go for an open reduction or something like this is no way to use the capsule as a capsule arthroplasty because the capsule is definitively too small. And then you can go for another technique. And the fascia lata or something like this is still a good option. Absolutely, absolutely, because there is no other way to solve this problem. Uh, uh, and again, my question is, Sergio, I could not clearly see, did you this operation by a surgical hip dislocation or no? I guess I would recommend, again, I know you, I guess even in South America, you know the word, there are different ways to Rome, and that you can go to the Pope. No, but there are better ways to Rome and not so good ways to Rome or direct ones. And you know, of course, this is typical. People try to go by variations also. But we in Bern, we have the knowledge, the skills and experience nearly of every approach. That means, as I mentioned before, for the mountains, there is a good way up to the hill, to the top of the mountain, and there are more difficult way up to the mountain. And we came to the solution, and this is the secret of our results, that the modern technique of surgical hip dislocation allows you, independent what you are posing, what you are interposing, fascia, free flap, or whatever, gives you the best handling of the problem. And again, I did not hear or see that you reamed your acetabulum. And so therefore, you agree your hips, but it's not only the operation you did, but it's also the reason because of the previous operation that the results are not as good as we like to see. That means if you take the criteria of coverage, of level, and so on, we can discuss a lot. But anyway, congratulations. And therefore, even you have such crazy cases, and there are really crazy cases. I would recommend to go and to try it really by a really open surgical dislocation. You will see a lot of your steps will be much easier. You see the better. And coming back to one of your cases too, I guess this is a problem. In our hand, we would not go even for capsuloplasty by fascia or whatever. In a case with this completely destroyed cartilage, as we have seen in the pictures. I guess this has, we know, not a long function. On the other hand, again, we are happy today, I guess, when we operate on patient between 10, 15, 20 years of life, and they gain again 10 to 15 years with a pain-free, good movement, then we can be happy. These operations are not forever. Even we have some cases now over 25, 30 years. But if we gain 15, 20 years of the life of this hip, pain-free in good motion, then we will have a really good success. And again, I have to criticize, not you, no, I will not criticize you, but the case itself. What I see, and this is so typical, you know, in many cases with the previous operation, we see variation. And did you realize that with this variation, you and your colleagues, you create so a crazy deformity and physiological deformity? In one of the first case, you made a variation of 90 degrees. So the gentleman alive is here, but the head is down out of the acetabulum. And this is the reason why this hip goes out again in the first case you showed. So the problem you have sometimes, independent of the colonna now, but in your hips, starts at the beginning. That means not a good solution and a good technique. But now, of course, you have to manage now these cases, these very problematic cases treated by other colleagues or sometimes also by yourself, but other colleagues. It's a good solution. But again, for this solution, you have to go in these cases. I would suggest to go by surgical hip dislocation. You will see you get a better result, especially to form a better acetabulum. Some acetabulum have still a critical situation, as you have seen and mentioned this. No, but
Dr.
congratulations.
Slongo,
Yeah.
thank you very much. I think we ran out of time.
Yeah.
I thank you. Ich werde jetzt auf Deutsch sprechen und danken Sie. Das war eine wunderbare Session und für uns es ist wunderbar, dass Sie hier mit uns sind in der Universität Javeriana. So, vielen Dank noch wieder für seine Zeit und alles. Vielen Dank.
Okay, besten Dank, kein Problem. Wir können uns noch einmal treffen.
Aha.
Ich denke, es wäre gut, weil das ist so ein schwieriges Thema. Sorry,
ja.
It's so a difficult approach and difficult cases. This is the high end up. I suggest that we can make a chat, perhaps only by 5 surgeons, to discuss some initial cases, how to do. And Sergio, again, I have not seen an initial case. In your case, you had all to operate really neglect bad cases. So go again to make this operation in a really neglect 10, 12-year-old hip, as you will see a lot of in your country. I know. Going this way, And again, we can make a chat.
Dr.
Okay,
Nosa,
Sergio, muchas gracias.
Muchas gracias
Hasta
también
luego.
por su tiempo. Hasta luego. Les deseo un feliz día para todos. A todas las personas que nos acompañaron en esta sesión en vivo de la Universidad Javeriana. Muchísimas gracias, Dr. Nosa. Muchas gracias, Dr. Slongo. Thank you very much for your time. Of course, we're going to make this chat for operating more cases, stick to the technique. So thank you very much for all your lectures today. A todos, buen día, que estén muy bien.
Very much.